Welcome to Partners in Pancreatic Cancer. I am Dr. Tanios Bekaii-Saab. I'm frequently asked, when determining the best treatment approach for patients with advanced metastatic pancreatic cancer, what are the key points that community providers should think about? And that question is very relevant to most community providers who don't actually see frequently see pancreatic cancer patients. And it's very important to understand that, over the last decade, we've done some significant improvements in treating pancreatic cancer. Now, it doesn't seem that it has caught up with most of the other cancers we work with, but nonetheless, if we look at the 5-year survival of patients with pancreatic cancer overall, it went from 4% closer to 8%, so closing down to close to 10%, which, for pancreatic cancer for 4 decades, we've been stuck in the single digits, and we're now moving into the double digits, hopefully soon. So there are differences to be made. For metastatic pancreatic cancer patients, we know that they present with a lot of symptoms: pain, nausea, weight loss. And a lot of these symptoms can be quite significant. When we think about patients with advanced metastatic pancreatic cancer, we think primarily of 2 things. One, we want to prolong their life, but we also want to make them feel better. And chemotherapy is primarily palliative. So patients actually do benefit from chemotherapy, not just in terms of their survival, but also in terms of feeling better. If the chemotherapy works, which it does now in more than 50 to 70% of the patients, i.e. shrinking the tumor or stabilizing its growth, patients tend to feel better. So that's a sizable number of patients. The survival curve has been shifting continuously to closer to a year at the median. For some patients, that had translated into survival of 2 years, and there's a 5% of the patients. 5% of the patients actually are surviving 3, 4, 5 years or plus. Now, that may not seem a lot, but it's sure beats 0%, which we've been stuck with for many years with gemcitabine alone. So I think the key here is to understand that, one, we are able to make a bigger difference in those patients' survival. 2, we have more treatment options available. In the first line, we have FOLFIRINOX and gemcitabine nab-paclitaxel. In the second line, we have 5-FU MM398 or nanoliposomal irinotecan. We also have possibly gemcitabine as a single agent. And then in the third line, for some patients, we may have oxaliplatin as an option. So overall, we're creating more options for these patients. So you really have to think about that patient that comes to your clinic. What are we looking to achieve? We want to prolong their survival. We want to make them feel better. We have different options. We have the options of going what I call the all-kitchen sink approach, which essentially means that we put all these three drugs together: 5-FU, irinotecan, and oxaliplatin. On the other hand, we have another approach which is a little bit more sequenced, with gemcitabine nab-paclitaxel, followed by nanoliposomal irinotecan, followed by perhaps oxaliplatin. There's also the importance of considering clinical trials. All these patients should be considered, if possible, and if feasible, and if a study is accessible, to be considered for a clinical trial. Because although we've made a difference and chemotherapy seems to have improved the outcome, clinical trials continue to be a very important lifeline for those patients, and hopefully will continue leading us towards the right path in improving outcome. So again, think palliation, prolonging survival, clinical trial, and think about exposing most of the patients that are eligible for treatment sequentially if possible. Last point, for those patients, when you're thinking about who should be treated and who should perhaps not be actively treated, but more at the time of presentation could be considered for palliative care and comfort care. This remains, unfortunately, about 10-15% of our patients with pancreas cancer still present at a point where they are not treatable. And those patients typically have a performance status of 3 or 4, so they're quite debilitated. Some of them present essentially on stretchers or in the hospital with very bad disease. Those patients probably won't benefit from treatment and should not get any active treatment, should be considered for palliative care. Fortunately for the rest, we should definitely consider them for treatment since they do seem to benefit from such. And this individual strategy will make a lot of sense. So thank you for viewing this activity.